So let's talk about randomized controlled trials. So up until this point, everything that we've talked about has been an observational study design. What does an observational study design mean?
We haven't truly completed, we just observed what's been happening.
Exactly. That's exactly right. We, as the investigators, have not actually manipulated any variables. We have looked at what's been going on, and we have maybe broken people up into different groups to analyze them, but we haven't actually physically said, you're going to do this and you're going to do that, right? If you recall, there's descriptive and analytical studies. The descriptive studies describe the person, place, and time of the population, right? They're describing who, when, and where of the disease that we're interested in. Analytical studies, we've come up with a hypothesis. We think that this is a risk factor for that, and we're starting to look at associations and correlations between exposures and outcomes. But we can't, in general, say that one thing is causing another. Now we're getting into experimental study designs. Now there's two key factors that make something an experimental study design, a true experimental design. Anyone want to guess what those are?
One of them's randomization.
Exactly.
And the other one would be like a null hypothesis.
Well, we always have a null hypothesis anytime we have hypothesis testing, but it's what we just stated before. So, manipulating. So, number one, yes?
In a control group?
Right, so you have to have a control group, but we have randomized. The key is not that we have some type of control or comparison group. The key is that we have randomized people to treatment groups. Random assignment to treatment groups. Must have random assignment to treatment groups for it to be an experimental design. You also have to have investigator manipulation of the independent variable. Investigator manipulation of the independent variable. Which variable is the independent variable?
The ones that like we change?
Yes, the exposure variable in this case. So when up until this point we've been talking about exposures and outcomes.
It's not what we're measuring. It's not what we're measuring.
It's not what we're measuring. It's not the outcome that we're interested in. It's what we think changes the outcome that we're interested in.
Say that one more time.
Investigator manipulation of the independent variable. Which otherwise stated means that I, as the investigator, assign a treatment to groups. I, as the investigator, somehow apply an intervention to the treatment groups that I'm interested in. So that could be I give one group drug A and the other group a placebo, or I give one group drug A and the other group drug B. Or it could be that I have a behavioral intervention, and so group A gets cognitive behavioral training and group B gets regular psychotherapy if I'm interested in some mental health outcome. But the important thing is that I, as the investigator, have decided that these are the treatment groups and I have applied the intervention. Now, there's different types of experimental studies that we can have. Randomized controlled trials are RCTs is what we typically think of when you think of an experimental design, especially in the medical realm. You're thinking about medicine and healthcare. Randomized controlled trials are just, we've taken individuals, we are randomly assigning them to the treatment groups, we apply our intervention, we assess our outcome. Group randomized trials are the same idea, except instead of randomizing individual people, you randomize groups of people. So instead of randomizing individual children within a school, I could randomize schools to treatment groups. Does that make sense? Field trials use healthy individuals as opposed to sick individuals, generally speaking, and they generally are not taking place in the lab, they're taking place out in the world. Community trials, similar to field trials, are taking place out in the community. The distinction between these, not hugely important. You'll just see kind of different people calling them different things. When you see things that are taking place in a highly structured lab environment, you're usually going to hear the phrase randomized controlled trials or RCTs. Field trials and community trials generally apply to randomized trials that are taking place not in kind of a confined laboratory setting, but someplace out in the real world, but they still have the highly structured environment that we're talking about, and you're randomizing people to treatment groups, and you're still applying an intervention. That doesn't change. But let's talk about clinical trials. All right. So there's 5 general types of clinical trials. The type of clinical trial indicates, the type of clinical trial indicates what the researcher is studying. It does not indicate the phase of research. So you've heard probably, how many have heard like phase 3 clinical trial? Have you heard things like that? That's not what this is. This is not the phase of research that we're in. We'll talk about that next. This is what you are looking to study. So treatment trials are testing new treatments for disease, or new combinations of treatments for disease. So I created this new drug, and I think that it cures disease X. And so I'm going to run a randomized controlled trial where I investigate my new drug against whatever the standard of care is. Or I think my drug in combination with the existing treatment is going to be better than the existing treatment alone, so I do a randomized controlled trial comparing those 2 groups. But I'm looking at a treatment for a disease or condition. Prevention trials are designed to find ways to prevent people from getting disease. So prevention trials take place before people are sick. So we're not enrolling ill people in our study. We're enrolling a group of supposedly healthy people to see if whatever intervention that we have will keep them from getting sick. Diagnostic trials are to find new methods for diagnosing disease. So I have a new test that I think diagnoses disease X. I have to run a trial. Remember back when we were talking about sensitivity and specificity and measurement last week or the week before? We run diagnostic trials when we're trying to look at instruments to decide whether or not our new test will diagnose disease. Screening trials, designed similar to diagnostic, but instead of diagnosing individual patients with disease, we're trying to look to see if our screening mechanism is working well. And quality of life trials are trying to find ways to improve the comfort and quality of life of people that are already ill. Now, before we can talk about individual research designs and different types of experimental designs, we have to go through some notation. This is pretty standard across the board, so if you happen to take another research methods class, you will probably see the same thing. R always indicates random assignment to your groups. X indicates that that's where you're applying the treatment or the intervention. And O indicates a point of observation, where you're looking and assessing people. So, once again, we'll go over the true experimental design's necessary features. When we're talking about randomized controlled trials, all randomized controlled trials are going to be true experimental designs. So we have to have one or more experimental groups. So it doesn't just have to be a group with the experimental group with the treatment and a control group without the treatment. You can have 3 or 4 different groups and compare different treatments across those. But you have to have at least one group where you're applying an intervention, and you have to have at least one group that is a control group. You have to have random assignment to however many groups that you have. Now, who wants to take a stab at the difference between random assignment and random sampling? We haven't talked about sampling really, but just for fun. Who wants to guess the difference between random assignment and random sampling?
In random sampling, you're pulling random people from the actual sample, or from the population, or from the sample that you decided. And then random selection is what you said, or random assignment. Random assignment is from that sample, you randomly assigning them to the control group or the
That is exactly right. So, here's the difference. I can randomly assign people to groups without having randomly sampled them. Random sampling means that I have the population and I'm randomly picking people from that population to be in my sample. Therefore, my sample should mirror the characteristics of the population. Random assignment could mean that I take whoever walks through the door but then I have random numbers generator or some other system, and I randomly put them in different groups. So that does not mean that they're representative of the population as a whole. Right? If I just take every single person that walks in the door for my trial, that's a convenient sample. That's just whoever decided to show up. They read the newspaper ad, they needed $20, and they show up for my trial. And then I randomly assign them to groups. And you're hoping that when you randomly assign people to groups, that it's going to even out the distribution of characteristics, and so your two groups at the start of your study are going to be demographically the same. Somewhat the same, right? That's your hope. That's what you're trying to do, accomplish in randomization. And then finally, the most important thing, we're testing the hypothesis that the experimental group is different from our control group on some outcome variable of interest. Now, there are situations called equivalence trials where you're trying to test that your experimental group is just as good as your control group. Those situations usually occur because you have drug A that's the standard of care, but drug A is really, really expensive. And so you have drug B. And drug B is really cheap. And so you just want to establish that drug B is as good as drug A. And then people can start taking drug B because you know you're not losing any of the efficacy, you're just lowering the cost, right? So that's a situation where that would be called an equivalence trial. But generally speaking, you're trying to test that the experimental group will differ from the control group on some outcome that you're interested in. And there's many, many different types of experimental designs. We're going to go over the basic ones. The most basic one is the pre-test, post-test control group design. This is the most classic experimental design. When people came up with the idea of experimental designs, this is what they came up with. So we start, and we gather all our people, they walk in the door, and we randomly assign them to either our experimental condition or our control condition. We then have our first observation, the pre-test, where we get everybody's baseline characteristics. That's the starting point. We then apply our intervention to the experimental group. We do not apply the intervention to the control group, right? Because otherwise they would be the same. So we apply the intervention only to the experimental group. And then we come back and we test both groups again at time 2. And in this particular design, we can see A, did people change between time 1 and time 2? And we can also say, did group 2 change compared to, is group 2 different from, is the experimental group different from the control group after the intervention? But this allows us to assess, so if whether or not they were different at the beginning. Because if they were different at the beginning, and they're different at the end, but there was no change in between, we know that our randomization didn't work, right? But if they were the same at the beginning, and then they're different at the end, we can say, okay, yeah, our intervention worked, or our intervention backfired, those people got worse, one or the other, right? But the random assignment is there to ensure that we have evenly distributed, that our groups are roughly equivalent at the start of the study. And then the pretest allows us to just ensure that that actually happened when we did our randomization. Sometimes it's not feasible to pretest people, either because you think the pretest is somehow going to influence what happens or make them change their behavior, or just because you don't have the time or the money. In that case, you can use a post-test only control group design. So you randomly assign people to the experimental control and controlled conditions, and you're just taking it on face value that your randomization worked. You're saying, yeah, we randomized the two groups, we believe that the randomization did its job, we're not going to assess it, we're just going to move on. You apply your intervention to your experimental group, and then you look at your observation at the end, after the intervention is over. So you just do the post-test. So this allows you to assess the difference between the experimental and control group after the intervention. But you can't tell if anybody changed over time, right? You only have the one point in time to look at. So, the Solomon group design allows us, if we're concerned, sorry, back up. So when I said the post-test only control group design, we might do that because we're afraid that the pre-test might influence the post-test. But then we're also concerned about the randomization. The Solomon 4-group design allows us to control for all of that. So in the 4-group design, we have 2 experimental groups and 2 control groups. Now these experimental groups are getting the same exact intervention. The only difference between experimental group 1 and experimental group 2 is that experimental group 1 gets the pretest and experimental group 2 does not. We then apply the intervention to the 2 experimental groups and we look at everybody at the end. So, when we do a design this way, we can assess, did people change from time 1 to time 2? We can assess, are there differences between the experimental and control group at the end of our study? And we can also look and see, did our pretest somehow influence what happened in the post-test? So, if, for example, we're doing a behavioral intervention, and we think that by asking people questions in the pretest, it's going to make them change their behavior. So let's say it's a nutrition and exercise intervention that we have that we're going to apply to people. And you ask the experimental and control group in the pretest a whole bunch of questions about their diet and about exercise and about their weight and their health. That can be enough to get people to change their behavior. So we have our nutrition exercise and we only look at the people that had a pretest, but we apply our intervention, but the control group people change their behavior anyway due to the pretest. At the end, we're not going to see any difference between the experimental and control group, right? Because an effect has bled over into the control group because the pretest spurred them all to start dieting and exercising. And so we can't assess, if that happens, we can't tell if our intervention was actually effective. But
Couldn't you just then use the pretest as an intervention? Because it would work?
yes, but technically it doesn't work all the time, so you want to see if your intervention above and beyond. But what happens is you diminish your effect size, right? So you might have this intervention that works really, really well, but if a whole bunch of people in the pretest change their behavior, then you're just going to find this much of an effect when really your intervention worked this much. So, in this group, because they only had the post-test, the pretest didn't influence them, we can see at the intervention, we can then say, okay, well, these 2 groups didn't differ at the end. But if these 2 groups, the experimental and control that didn't have the pretest, did differ at the end, well, maybe there was some problem with the pretest effect, and the pretest caused people to change their behavior, and our intervention does really work really well, but it only works really well if you haven't primed everybody to start dieting and exercise anyway. Does that make sense? So we're able to control for all the factors. Anybody think why we might not do this all the time? Why wouldn't this just be our standard go-to?
Need a large amount of people.
You need a ton of people to do this. And so it gets crazy expensive crazy quickly because you have to have enough people in all of your treatment groups to be able to statistically assess whether or not you're seeing an actual effect. Now, design, which helps deal with some of the issues of needing a bajillion people to do this all in 4 group program.
Because in the crossover design, each person counts as their own control. So, you randomize people to 2 groups. And at time 1, experimental group 1 gets drug A, and experimental group 2 gets drug B. So let's say drug A is the drug that we're interested in seeing if it's good, and drug B is the standard of care. So we let experimental group have drug A for a while, and we let experimental group B have the standard of care, or experimental group 2 have standard of care for a while. Bless you. And then we do an observation. And we can assess the differences between those groups. And then we let everybody get rid of the drugs in their system, and we switch the 2 groups. And now experimental group 1 is getting drug B, and experimental group 2 is getting drug A. So we now we can assess the differences between the 2 groups, but we can also assess whether or not, so if we want to know if drug A is better, and we give group 1 drug A, and then a washout period, and then we give them drug B, and you found that they were doing better on drug A than they were on drug B, those are the same people, so you've controlled for some of the variability between individuals. You now have a stronger case that drug A really is better than drug B because you've been able to demonstrate differences between groups, and you've been able to demonstrate differences in the same people across time. Can anybody think of a reason why this might not work for some interventions?
Maybe it's a drug that like stays in their system for too long or something like that.
Yeah, so, or not just, it doesn't necessarily have to be a drug, but if it's some type of intervention that permanently changes the person, and you can't, so if it's a behavioral intervention, you can't make people forget that they had cognitive behavioral training, right? You can't just, like, wipe their brain. They do it in movies a lot, but they don't do it in real life, as far as I know, unless you, like, lobotomize the people, which is probably not the best way to do that. So there are some interventions where this just isn't possible. So this is great for drugs where you can have a quick washout period and then they don't have any drug in the system and then you switch and do it. And you know, this is the standard for pharmaceutical research for drugs that kind of fit that criteria. Because it has higher statistical power and it takes fewer individuals to be able to assess treatment effects using this type of design. All right. So, at the very beginning of class, I mentioned that experimental designs are not my favorite study design. I don't have anything against them, but there's some issues with experimental design. So experimental designs are viewed as the gold standard of research. Frequently, you will see that cited in textbooks. People talk about it all the time. They're like, it's the gold standard of research. It's great. Why would anybody say that this is like, that experimental designs are just like the supreme being of research?
So that's like the prime example we're showing since kindergarten.
Yes, we are shown that since kindergarten, right? But why?
It's straightforward.
Sometimes. It's even more basic than that. What are we really trying to find out when we're doing research?
Cause and effect.
Cause and effect, exactly. Experimental designs are the only type of research where you can say at the end of your study, yes, this caused that to happen. Assuming that it was well designed and well controlled. But experimental designs, you know that your intervention, your exposure is coming before your outcome, right? You know that depending on the type of trial, people weren't sick at the beginning, or people that were all sick, these people got better and these people didn't. You have controlled, you have strongly internally controlled for all the variability that could create confusion as to the cause and effect. So randomized controlled trials and other experimental designs have high internal validity. High internal validity just simply means that validity, assessing validity, that just simply means that the truth. Like, if something is valid, then you're measuring what you think you're measuring. You're assessing what you think you're assessing. You're getting the true answer. If it's a valid answer, it is a true answer. It is what really is going on. Well-done experimental studies have high internal validity. The problem with them is that they have very low generalizability. Who wants to guess what generalizability means?
You can't take your facts from this little small group of people and then apply it to everybody.
Exactly. So if you have so tightly controlled your study that the only people that ended up included in your study were people that were from the ages of 20 to 30, and they only had one condition, and they all had blonde hair, and they all just, when you so narrowly define to tightly control the internal validity of a study, you lose the ability to truly generalize back to the population. Because the real world is messy. And in the real world, people usually have more than one disease. And in the real world, people usually have a ton of other factors that may influence whether or not this drug or this intervention is going to help them. So you get a lot of you get an answer when you do an experimental study. You usually get an answer. Does this cause that? But what you don't get is, does this cause that for everybody? Right? So you lose the ability to generalize to larger population. Now, depending on the study, really large trials usually have some generalizability, some decent generalizability. But we take these studies and we hold them up as like the true gold standard when we don't necessarily know. We know at the end of the trial that this drug works for this population, for this tightly, narrowly defined group of people. It doesn't necessarily tell us that, yes, this intervention is going to work for everyone. Now, let's talk again about randomization. Randomly assigned. So the sampling, when you randomly sample people, that's when you have stuff that you can generalize back to the larger population. Because when you've randomly sampled people, you are attempting to ensure that your sample looks like the larger population. Mm-hmm.
Why can't you randomly sample at the beginning, then randomly...
Theoretically you could. Like, it's not an impossible task, but logistically it's pretty impossible, especially when you're... So let's say you are looking at people with diabetes. That, if you truly wanted to randomly sample, you would have to do some type of really sophisticated sampling out of everybody in the entire United States. Well, let's say we're defining our population as people with diabetes in the United States. We would have to take a random sample of everyone in the United States that has diabetes, convince them to be in our study, then randomly assign them to treatment groups and keep them in our study. And that's kind of an impractical thing to do. So generally speaking, we don't do that. Not to mention the fact that if you randomly sample, you can't control for a lot of the other factors that you might be interested in. So let's say we're really only interested in, we want to make sure that our treatment is really working on people that have just diabetes. Well, most people with diabetes have some other type of comorbid illness, or they're also they're further along in their diabetes state than others. You can't really tightly control the inclusion criteria when you do it that way. So it's not that theoretically it's a possibility and it sounds like a really great idea, but logistically it's kind of impractical. So generally speaking, when we're trying to get at the right answer, we want to tightly control who gets included in the study, and that's what we do in experimental studies. It's really tightly define people that are going to be allowed here. And then, and when we're randomly sampling people in the population, we generally have looser criteria for who we're including. But randomization to treatment groups is trying to say, okay, well, we've taken everybody that walked in the door, we've taken this group of people, and we know they may not be the same as the general population, but we're at least going to try to evenly distribute their differences across the groups, right? So that we don't end up with one group that's a whole lot older than the other group. And random assignment helps deal with that. Now, a lot of times in experimental research, you hear about the use of placebo. True placebos, a truly inert substance, is rarely used in research. Because generally speaking, especially if you're talking about treatment trials where people actually are sick, if there's an existing treatment, you cannot ethically withhold that treatment from them. So usually when you have an experimental design, you're not comparing to a placebo, you're comparing to the standard of care. Does that make sense? Now, placebos do get used when there is no standard of care. If there's some rare illness or if there's some treatment that there's nothing that's equivalent, then you might see placebo use. But it's not very common to see placebos utilized in experimental research anymore. I want to take a stab at what blinding is.
Kind of like double-blind studies where the researcher doesn't know who's on which group and the people don't know which people are in the group.
Mm-hmm.
Or like, people just don't know where they are.
Exactly. So you can have single-blind, you can have non-blinded randomized controlled trials, you can have single-blinded, and you can have double-blinded. Blinding simply means that you don't know which group you're in. So in a single-blind study, the participants, the subjects that are in the study, don't know if they're in the treatment group or the control condition. But the investigator does know. In a double-blind study, neither the investigator nor the participants know which treatment group they're in. Why would we want to do this?
Because you don't want any bias in your study. You don't want the investigator to know who's getting the treatment, because then you might skew the results. And you don't want the patients to know what group they're in, because then they might do something different if they know.
Exactly, that's exactly right. And by investigators biasing the results, that doesn't necessarily mean they're intentionally biasing the results. But there's a lot of things, so if you're a clinician and you're treating a patient and you know that they're in the treatment condition, you may inadvertently treat them differently or give them a different test or change their treatment somehow differently just because subconsciously you know that what condition they're in. So the true gold standard for medical research is a double-blind randomized control trial. Now, there's a lot of times when it's not possible to keep the investigator blinded to the condition. If you're doing surgeries, probably hard to keep the investigator blind to what type of surgery they are doing, right? There are single-blind surgical studies where people get sham surgical procedures. So that's fun, right? No, not sure I would want to sign up for that one, but yes, there are certain studies where people get procedures where they just open them up and sew them back up and say, yeah, you had surgery, as a placebo, and those people that would be a single blind study. Those are rare. It's not a common occurrence, but it does happen. But we blind to try to diminish the bias. And then there's a lot of ethical considerations that go into experimental research. We're going to talk more about ethics towards the end of the semester. I probably should start moving that to the beginning of the semester. All the textbooks always have it in like the first 2 chapters, and I always talk about it at the end. I don't really know why. I like everybody to come up with all the like highly unethical things that they can think of, like as the semester, and then I'm like, no, you can't do that. But so there are a lot of ethical considerations that can come up in experimental research, but in general, you need to know when you're designing a study, you want to say that some group, your hypothesis needs to be that your experimental group is going to improve or at least be as good as your control condition, right? It would be really highly unethical to conduct a study where you think that your experimental group is going to do worse than your control group. You laugh, I had someone propose one of those studies like 2 days ago. And this guy's an MD. I don't think he thought about it in that capacity, but it's not as bad as it sounds. But yes, it does happen. So, and you don't want harm to come to people, which is why standard of care usually uses the comparison, because you don't want to deny people care when a treatment does exist, for whatever the condition is. There's a lot of other issues around informed consent for experimental studies, but we use informed consent for people that are participating in any type of research. But in general, there are some ethical considerations that come up with experimental research that you don't have in observational research, because you can't give somebody something that you think is going to be harmful. Right? So we wouldn't be able to randomize. If we were interested in the effects of smoking, we couldn't randomly assign a group of people to smoke and a group of people to not smoke, because we know that smoking is harmful. Yeah.
So if you thought like a prescription drug was like harmful that had gotten on the market, would you just have to start using a sample of the people who are already using it?
So that comes in phase 4 post-marketing trials, and so that usually, analysis like that usually come from secondary data sources. So what happens is drugs get approved for market. We're going to talk about phases of clinical trials in a second, but so you go through phase 1, 2, and 3 trials, and after phase 3 trials, which are the big trials where people, where they give the drug to a whole bunch of people to determine whether or not the drug is efficacious, and once you've done that, then the drug can be approved for the market. But what happens is, it gets approved for the market, and now you take a drug that was originally given to 600 people or 1,000 people, and you give it to 20,000 people. And when you start giving it to 20, 30,000 people, you start noticing little things that didn't show up in your clinical trial, right? And so that's why drugs are tracked once they've gone on the market, because then all of a sudden, once you start giving them to mass amounts of people, and mass amounts of people that have other illnesses and are taking other drugs, then you start to notice these other things that come up, and so that's why all these drug indications are tracked after the fact. And so those are called phase 4 trials. These are taking place after things have gone to market. They're technically not randomized controlled trials. All right. So I know I keep beating the random assignment thing to death, but it's a very important concept. It is, if you get anything from the lecture today, you should get the concept of random assignment to groups. Because you cannot have a true experimental design if you have not randomly assigned people to groups. So when you randomly assign people, it means that each person in your study had an equal chance of ending up in one group or the other. So you may have a convenient sample of volunteers that walk in the door, but anybody that walks in the door has an equal chance of being assigned to the treatment group or the experimental group.
The treatment group or what?
The treatment group or the control group.
Okay.
Yes. Thank you for pointing that out. One of the treatment groups. So when we're randomizing the groups, we want to obtain two samples that are as equal to each other as we possibly can. We want two groups that are virtually identical in demographic characteristics and underlying baseline severity of the illness. Anything you can think about, we want the groups to be similar at the start of the study. Why is that so important, that the groups are similar at the start of the study?
It's a controlled variable.
Yeah, essentially we're controlling for, if everybody's the same at the start of the study, then all that variability has already been dealt with. And now the only thing that's different between the groups is our intervention, right? So we want the groups to be the same, because if the groups are the same at the start of the study, then that means that the only thing that's different in our study between those two groups is our intervention. And if the only thing that's different is our intervention, then we can be much more confident that it was our intervention that caused the change, right? So this helps us avoid systematic bias in our results. All right. View placebo. This is, I guess, the technical definition of pharmacologically inactive substance, given as a substitute for an active substance. A lot of times people hear it as sugar pill, but placebo indicates any pharmacologically inactive substance, or any thing that's designed to truly change whatever. That was the most inarticulate statement in the world, but that's okay. I think you guys get the point of what a placebo is. Why is it important to have a placebo? Or to have some type of comparison?
Because like whenever you have the comparison, you're able to tell if people just like think they're getting better versus actually getting better.
Exactly. Which is called, do you know what that's called?
Placebo effect?
It is called the placebo effect. Sometimes people get better just because you give them something. It's crazy. You would think this would just be with psychological stuff, but it's not. It's with physical, clinically diagnosed illnesses. You say, hey, I'm giving you this medicine, and they miraculously get better. So because you can expect that by telling someone that you're treating them that some people are going to get better, you want to make sure that your treatment isn't just that happening. If you didn't have some type of comparison group, if you just gave your treatment and said, hey, look, they got better, you don't have any way of saying they got better because of my treatment versus they got better just because they were going to get better because I told them that they were getting a treatment. If you have some type of comparison group, be it placebo or standard of care, you can say, hey, my people got better above and beyond what would have been expected from just the general, I'm telling you that you got a treatment and therefore you're going to improve. Blinding, we already talked about, but we'll talk about again, obviously. So single and single blind, the subjects don't know which group they're in, the investigator does. In double blind, neither the investigator nor the subjects know which group they're in. Now, blinding is held up as the gold standard. There have been a couple of studies done to look at whether or not blinding actually works, whether or not the investigators truly know, are truly blind to the situation, or whether the people that are in the study are actually blind. Blinding is not as effective as one would like it to be, because generally speaking, you may blind the investigator, but there's going to be some kind of clinical manifestation that the doctor's going to pick up on, right? So it may be you were told that you don't know which two groups these are in, but the serum creatinine levels of Group A are drastically higher than the serum creatinine levels of Group B, and that wasn't one of the outcomes that you were looking at, but it just happens to be a side effect of the treatment. And so it's pretty easy to parse out who's in the treatment condition and who's not, just because you can look at those lab values. And so there's a lot of indication about that blinding may not be as truly effective as we would like it to be, but that doesn't mean it shouldn't be something that should be attempted. It's just unfortunately not usually quite as effective. I can't remember exactly what, I need to look up the study. I want to say it was like 70% of researchers actually were able to figure out most of the people that they, what groups they were in, of the ones that were surveyed, but I could just totally be making that number up, so don't quote me on it. That's just the one that's popping in my head. I'll find out what the true number is, and I'll get back to you on that one. All right. So experimental studies are tightly controlled, and because they are tightly controlled, they can be difficult to do. So you have to convince people to get into your study, and then you have to convince people to stay. And so the people that are in the study have to be committed. Like, they have to try. They need to show up for their appointments, because generally speaking, you're asking them to do something they wouldn't normally do. You're asking them to do something above and beyond what they would typically be doing for their care. You're asking them to come to more doctor's appointments. You're asking them to fill out more surveys. And so you have to have people in your study that are willing to actually comply with the study. You have to make sure if your study involves taking a new pill, that those people actually take the pill. Because your pill could be really, really effective, but you will never know if people in the treatment group don't actually take it. So you have to have participation and cooperation from your study participants. If people do not take their medicine, then your treatment group and your control group are going to look the same at the end, right? Because there won't have been any change. The drug wouldn't have been given the opportunity to work. So how do we fix this? Well, sometimes you just, yeah. Nope, what do you say?
Incentives.
Incentives, yes. So incentives are one thing. So you say, okay, I will give you $20 if you are in my study. Now, there's a fine line between incentivizing and coercing people to doing things. Generally speaking, the more dangerous participation is, the higher the compensation for participating. So leads us back to the ethical issues surrounding participation in research. So the IRB generally will help decide what is fair compensation for participating in these types of studies, but a lot of these studies do actually have true risk of harm associated with them. Now, the risk of harm is less than, is deemed minimal or is deemed okay due to the potential for benefit, but so generally the amount of compensation that people are given is roughly equivalent to the amount of danger they're putting themselves in when they participate in the trial. That's why when you're asked just to do a simple little survey, you usually get like a $5 gift card to Walgreens or something, right? Because then they're just compensating you for your time. Whereas if you are asked to do something where they spray lidocaine into your lungs and like pull out macrophages and involve you like being anesthetized for a couple hours, you make a lot more money. I did that when I was in college. It was not fun. I do not recommend participating in one of those trials. But see, I was broke, and so I did the highly dangerous trial. And I think it was a couple months later where some guy died from a very similar trauma. Oops, from a very similar situation that I had. I was like, maybe this was not the best idea, because I think I only made like $500, and it's not. But anyway, not to discourage you from participating in clinical trials. Just don't do it so you can like buy a dog or something, which is what another friend of mine did. And he did the like stay in the lab overnight research, like they do blood draws every 2 hours thing, because he decided he needed this $1,000 dog. whatever motivates you. But back to what do we do? Yes, compensation is one way to enhance compliance. Another way is to only let people in the study that you think are going to be adherent. So there's a lot of studies where they'll do like a 2-month run-in period. So they'll enroll people, and then they'll go for 2 months just to assess adherence. So they're not actually looking at the study drug. They're just assessing whether or not people will take what you're giving them when you're asking them to take it, and then the people that are non-adherent don't make it into the study. There's some other methods, but those are kind of the big ones. Alright, it's also important to minimize loss to follow-up. So once you've gotten people into your study, you want to make sure they stay there. Kind of the same thing we're talking about. You don't want them just to be adherent, you want them to not disappear. So once they're in the study, you want them to stay, because if you can't follow them out till the end, then you can't assess what happens, and it messes up your data, and it's just not fun. You're going to make your statisticians crazy. You also want uniform follow-ups across your treatment groups. You don't want to give everybody the pretest and then do the intervention and assess the control group at the same time you give the intervention to the treatment group, and then assess the treatment group 3 months later. Everything that happens to the experimental group should happen to the control condition with the exception of your intervention. But everything else should be the same between the two groups. And finally, intention to treat analysis is kind of the big deal. So intention to treat analysis says that if you lose someone, if someone disappears from your treatment group, or if someone's non-adherent, it doesn't matter. You still analyze them as if they had completed the study, and as if you analyze them whichever group they were in. So if someone starts the study in the control condition, and then halfway through their disease status changes really bad, and something happens, and their physician decides to put them on a new treatment that is different from what the protocol, doesn't matter. You still assess them and analyze them as if they were in the control condition the whole way. What this does is it diminishes your effect size. If you have a lot of loss to follow-up, if you only have 1 or 2 people, it's not going to make a difference. But what it does is it ensures that you're not artificially inflating your effect size by saying, okay, well, this person was in the control condition, but we think they got some of the treatment, so we're going to put them in the treatment group. Or this person was in the treatment condition, but they never took their meds, they were completely unadherent, so we're going to put them in the control group. Can't do that. Not cool. You have to say if somebody was in the treatment condition at the beginning, they get answered if they were in the treatment condition at the end. Alright, briefly, phases of clinical trials. So there's 4 main phases, 3 that occur pre-market, 1 that occurs post-market. So, phase 1 trials are your initial studies to determine just the metabolism and pharmacologic actions of the drugs in humans. So basically, you have your bench scientists that sit there and study with their test tubes, and the people that do the animal studies, and once those have said, okay, we think it might be safe, then you get 10 people and you say, hey, take this. No human's ever taken it before, but you can do it. That's great. Let's see how it affects you. Those are the phase 1 trials. These let you look at side effects that you might not have seen in the animals. They allow you to look at increasing doses and to gain early evidence that it might be an efficacious treatment. Phase 2 trials. So you said phase 1. You finished your phase 1 trial and you said, okay, in this very, very small group of people, we think this drug looks like it's doing something. It didn't have horrendous side effects. It seemed like it was okay. It wasn't too toxic. We go to phase 2 trials. And these are when we're looking at the efficacy of the drug for a particular indication. So for one purpose, in patients with our disease of interest, to determine just the short term, does it work? And does it have huge side effects or risks? So we're getting a little bit bigger, we're spreading the risk out to a few more people. We're looking to say, are there any big side effects that we need to be that should keep us from moving forward?
So what exactly is phase 1, and that's just when they kind of come up with it?
So phase 1, it's been developed in the lab, it's gone through animal testing, and it's the first time it's ever given to people.
Okay.
And then phase 2, we gave it to those 10 people in phase 1, they all seem to be okay. So now we're going to expand it a little bit And we're going to look at if there's more if we give it to more people, do we notice some other side effects? Do there seem to be huge risks associated with this drug? Does it still seem to kind of be working? And then once we move past phase 2 trials, we get to the phase 3 trials. And these are the trials we typically think about when we think of drug trials. These are the big ones. So these are the expanded trials where we have preliminary evidence that this drug is efficacious. We have preliminary evidence that this drug kind of works, that it's not, effects aren't too scary, we don't really think it's going to kill anybody. So then we move on to the phase 3, and so we have a whole lot more people. And this is when the phase 3 trials are when we say, okay, does this drug work? That's when you finally have enough people to make comparisons to true comparisons, large comparisons, hopefully somewhat generalizable comparisons. Yes?
Do you have an example of phase 3?
Yes, I will. Yes. I think in my, I don't have them. They're in my other, I will give you some. There's lots and lots of things. Actually, no, I do. I have in our homework. I mean, not our homework, our class assignment. The phase 3 trials are the last trial that are required before a drug goes to market. Now, whenever you have these trials, the phase 3 trial, it is looking at one drug, possibly a couple of doses for one indication. So if you then want to look at that drug to see if it treats something else, so let's take Viagra, for example. Viagra was actually a heart medicine. It's a vasodilator that people were given, people that had heart conditions. That is why over the course they noticed that it had a little side effect. They said, maybe we should assess this side effect. And I think there's lots of money in this potential side effect, right? So initially, the ability to get an erection was not what the drug was designed for. There was a phase 3 trial that was done to assess its ability to improve people with heart conditions. I don't remember exactly which conditions it was. And it was determined that it was efficacious for that. They put it on the market. They got it on the market, and lo and behold, all these people started requesting it for other reasons. That's what's called off-label use. So the FDA had not approved it yet. But there was a side effect and said, maybe we can use this. So then you had to go back and do another phase 3 study. And that phase 3 study assessed whether or not Viagra was effective in creating erections in men with erectile dysfunction. So it went through, it didn't have to go through phase 1 and phase 2 trials again, but it had to go through another phase 3 trial in order to be FDA approved for that use. So each time you take a drug, if you want it to be FDA approved for a new use, you have to conduct a new phase 3 trial. This also holds if you want to make a change to the recommended dose for a use. You have to do another trial, which is why there's so much off-label prescribing that takes place, because it's expensive to do these trials. And so if you have a drug that's relatively safe for most people, that you kind of figure that out, you know it has a side effect, people start using it for other reasons. So I think, I actually don't know if birth control pills have ever been studied for treatment of acne. They're prescribed for that all the time, but I don't know if they ever went through trials for that. Or there's a lot of stuff that's been approved for use in adults that people use in children. If you want to change the population of use, that's another reason you would have to go back and do a trial. So things that are approved for adult use, you have to do a separate trial if you want it approved for kids. Now, the phase 4 trials, what we were kind of talking about before, these are the post-marketing studies to look at to see if there's any additional risks or benefits. So this is when we start picking up these crazy side effects that may be good and beneficial and marketable and the drug companies love, or maybe killing people. So Vioxx, does anybody remember Vioxx? I think you guys are probably too young to remember the giant Vioxx issue. So we have 2 people that remember Vioxx. So Vioxx was a non-steroidal anti-inflammatory drug. NSAID. Anyway, like Tylenol and Advil, but a whole lot more high-powered. Anyway, so people would use it for pain. A lot of people use it for arthritis. They use it for some other stuff. And in all these trials, So they did the clinical trials and found that it was good for pain, but when they busted it out in the huge in the total population, they noticed a lot of people started having heart attacks. I think it was heart attack. Pretty sure it was heart attacks. And they didn't actually. This effect was evident in their original analysis, but it was just kind of like it wasn't a main outcome, and since it wasn't a main outcome, it wasn't a big focus in the paper, and it wasn't a huge effect. But what ended up happening was then when it got out of the market, all of a sudden people were saying, okay, all these people that are on Vioxx are dying. I don't remember if they were having more heart attacks or if they were more likely to die if they had a heart attack. It was one or the other. I'll go look up that paper. But it wasn't until after it got distributed to the population and a number of people started taking it that they noticed that this was a problem. Because sometimes if only 1,000 people have been in your study, that seems like a lot of people, but there's a big difference between 1,000 and 1 million. And when you have 1 million people have a whole bunch of different things going on, you might start to pick up some things that you didn't notice before. So the phase 4 trials are really just these post-marketing studies where we're looking at what's going on after the fact. Are there additional side effects that we didn't know about? Is the drug really safe in this large group of people? Are there subgroups of people that we didn't know about for which it works better or works worse? So as epidemiologists, right, we're interested in subpopulations. Well, in our clinical trials, we may not have enough people to look at subpopulation. But so there's some medicines that are actually more effective for certain ethnic groups than others, which probably has something to do with genetics. I'm not a geneticist, but that's the general idea. But you don't notice those things until you start doing these larger studies when you have enough people to actually look at. And the phase 4 trials give us a sense of the real world effectiveness. Notice I changed my term there. So efficacy means does the drug work under perfect ideal conditions? So when we're doing randomized controlled trials, we're looking to see if the drug is efficacious. Does it work in the perfect scenario? Effectiveness means does it work in the real messy world? So now that we're giving our treatment to a bunch of people that have a bunch of comorbid illnesses and are on 20 different other medications or have 20 different other things going on, does it still work? When you prescribe in the real world and people are only taking their drug 80% of the time instead of 100% of the time, is it effective then? So these post-marketing studies are looking at effectiveness, which is our earlier studies were looking at efficacy. All right. Now, this covers pretty much all of the study designs that we have gone through till this point with their positives and negatives. We didn't really talk about case studies or case series, but that's really a person walks in the door and, hey, they're really interesting, let's write this up and send it on its way and publish it, right? Case studies and case series are really only good for those really crazy rare occurrences, like when somebody gets stabbed through the brain and lives and their personality changes or something like that. Those things get written up for case studies. But this is a table you might want to on hand and study prior to the midterm, maybe. All right. Any questions about what we have covered up to this point? All right.